You mean that worried couple on the insurance company's commercials?
They're so confused about health care.
And you're confused because they're confused.
They keep saying there's got to be a better way.
There is. The single-payer system. Everyone is covered, you get full benefits, and you choose your own doctor.
Harry and Louise, there is a better way.
Say, if you as an American citizen said the government cannot solve problems, what you're saying is,
I see.
I mean, I'm not proud of it. I'm not a child anymore. You know, I can deal with problems that come to me in my life. What do you call it? And this is my government. The thing is that you no longer participate in our work. People who say that. So that's the message that's it. Now, the problem is that the government to some extent is hidebound, and it is inefficient. So you have to go back to some of the things that I said. So, you know, it really isn't, first of all, the single payer doesn't have to be the government. That's the first thing to remember. Anybody can be a single payer. For example, Nationwide is a single payer for Medicare in the state of Ohio. It doesn't have to be the government. It could be Nationwide, for God's sake, if you wanted it to be. I mean, it doesn't have to be the government. Okay? The one thing the government does well, and they do it to me every April 15th, and I bet they do it to you too, is they collect the money. You know, you let them collect the money and then give it to you. If you don't want to have no organization, create a community organization of some sort whose responsibility it is to maximize the effectiveness of the health system. Turn the money over to them as a single payer. Let them negotiate. Now, who could that be? It could be a public utility. It could be, I mean, there's a doctor, Tom Bodenheimer, a genius out of California, who has written a paper called Who Should the Single Payer Be? He works out of a private office in California. I can give you his number if you want it. There's probably even have it here. I can give you somebody who could certainly, in one phone call, give it to you. And he's amazing. He wrote an article several years ago talking about this because he figured this would become an issue. You know, who should it be? And he talked about all the different structures in this country we use to handle things together as a community. Whether it's a community board, a community council that's elected, a public utility. I was talking about...
Hi, Bob Petrakis here with a special edition of Free Press Forum. As you know, we've been dealing with health care repeatedly on my show and as well as in the pages of the Free Press. Today we're here with Dr. Jonathan Ross, who is with the Physicians for Social Responsibility. We're going to be talking about a variety of things. Health care, the ballot initiative that's going on for single payer in California, as well as what's happening here in Ohio. Dr. Ross, how'd you get involved in this battle? Usually we think of the physicians as the ones that are opposing single payer.
Yeah. Well, actually, there's 6,000 of us across the country now in an organization called Physicians for a National Health Program. And we've been actually working pretty hard to push single payer along and have been pretty active in that movement for a number of years now. I happen to wander into this kind of from a very unusual perspective. I've always been interested in public health issues and have a master's degree in public health in addition to being a board-certified internist. I take care of patients that are both some of the most well-to-do in my town of Toledo, as well as some of the poorest because I run an inner-city clinic for a Catholic hospital there. But during the 1980s, we ran into a problem at our inner-city hospital, which was that we wanted to get adequate reimbursement for taking care of our Medicaid patients, and the state of Ohio was having problems funding that. And we began to look into alternative approaches to handling Medicaid at that time, which included forming a Medicaid health maintenance organization up in Toledo that took care of both private sector and as well as these folks that were on state Medicaid, primarily for AFDC, that's women and dependent children. So this sort of experience of putting together a health maintenance organization and then trying to work with the insurance industry to see what it was like to compete in that environment of trying to provide managed care in the Toledo environment has taught me a lot about what the basic and fundamental problems are. Between that and my experience in getting a degree in health management at the School of Public Health at University of Michigan, and my experience working in an inner-city clinic, I see up close and personal the sort of problems that the healthcare system has and how insurance in its current structure has aggravated that. And it's through those experiences that I've come to believe that the only way we're ever going to get down to a system that will provide comprehensive benefits to everybody and do it with a high level of quality will be through a single-payer system that's publicly controlled.
Now, you're really talking about the Canadian-style single-payer system. The critics have been claiming that this is going to cost us a fortune, it's bureaucratic, it's going to bankrupt the country. How would you respond to that?
Well, what I guess I'd say to you is that the insurance industry is bureaucratic. It's costing us a fortune, and it's going to bankrupt the country. I mean, that's exactly what our problems are. That's why we're trying to work on healthcare reform as it is. Those are the fundamental issues. We pay too much and we get too little for what we're paying for, and most people fundamentally understand that. The Canadians, on the other hand, are among the happiest people in the world with their healthcare system. Not only that, their doctors are well pleased with it as well. That's very well documented. There's been a lot of what I would call disinformation in the American press. My group, Physicians for a National Health Program, did their spring meeting in Toronto. We went up and talked with a number of doctors and people that were working in the healthcare system up there, and they say, "What are you guys talking about? What is all this stuff you say? You know, people wait in line when they're sick, and it's just none of it true. You know, so why are you putting these slides
Rush
out about it?"
Limbaugh says all those doctors are Canadian doctors come to the United States when they want health care.
It's not true. I mean, it's absolutely not true. You have to remember, first of all, that Canada is a pretty small place. I mean, there are 20 million people. So we're really not talking about a 27 maybe, I think it is. It's not a huge country, and we're talking about a place where they really don't have all, perhaps, the exotics and facilities that we have down here. But if on every comparable health statistic, on every evaluation of their ability to deliver high tech to their population, they are comparable. They are equal, and those things are documentable. For those that are skeptics, when you have somebody who says, "Oh, the Canadians don't do this," what I usually say to them, "Show me the documentation." And they can't. And then I show them the documentation that I have that shows that they're doing an excellent job. Now, what's amazing about it is they're the second most expensive system in the world after ours, okay? They're number 2. But they do it with almost $1,000 less per person per year than we do. If Canada was the size of our nation, they would spend $250 billion less per year to provide the same level of care. And the reason is we're eliminating such a tremendous amount of insurance bureaucracy.
So you're eliminating the 1,600 or so insurance agencies. You'd also, I would understand, you'd be limiting 50 state bureaucracies for Medicare and Medicaid. Would that be rolled into the system? Would that be a savings as well?
The national system rolls the money for Medicare and Medicaid into one big pot. We're talking about having one pot of money that we're going to pay for. What we'd like the federal government to do is to collect the money. That's the one thing they do pretty well. At least they do it pretty well to me every April 15th. I don't know about you, but they seem pretty successful at that. And we ask them to collect the money for the system. Then what we would like to do is to farm that money down on a per-head basis, primarily to appropriate-sized medical communities, and then have community boards, basically, that would be responsible for making sure that that money was well spent
Would these
on
be
a local basis.
appointed, elected? How do you
Actually,
envision these boards?
it's been different in a number of different single-payer bills. In the national single-payer bill, they defer that to the states. They don't talk about how it goes from the state level down. So, for example, the McDermott-Wellstone bill that was in front of Congress, with about 100 Congress people in support of it, had proposed that you would delegate that authority to the state to decide how to step that money down. The Fed would collect the money, they would give it to the state. The state would have to have some sort of arrangement or authority. A small state like Vermont, or a very low population state like Wyoming, you might have one payer for the entire state. Some place like Ohio, we might have 5 regions. It's possible in this state, each of which might be 1 million or 2 million people in size, which would be plenty big to have most of the high-tech that you'd want, maybe a few statewide regional high-tech centers for things like, exotic transplants and other experimental sort of research for the state as a whole.
Yeah, we've talked to some Canadian providers on this show, and I've been at conferences. I've talked to the head of the Danish system. What they pointed out that American statistics are close to 1 biller for every doctor, as opposed to their system with one form. You only need 1 biller for hundreds of doctors.
Yeah, it seems like the philosophy that the insurance industry has is, there are 2 ways to control costs. You can build a fence, or you can hire a cowboy to ride each one of your cows. You want to control the cattle, and that's one way to do it, but it's awful expensive to hire a cowboy to ride each cow, and that's true. We have a bureaucrat looking over every doctor's shoulder, trying to see what they're doing and how they're doing it. And I think that heavy layer of insurance bureaucracy is exactly what we're trying to get away from. Single payer proposes to take the 20 to 30 cents on the dollar that we currently spend on insurance bureaucracy and profits and unnecessary paperwork, and instead provide care for people that need it now, provide long-term care, provide medication, provide full hospital and physician coverage. And the amazing thing is that it's been looked at, and with the money we're spending now, we can do that. we can give you full comprehensive benefits, medication, and long-term care with no out-of-pocket expenses with the money that we're spending now if we eliminate the insurance bureaucracy.
So is your argument then that the single payer, and I know the General Accounting Office argued this as well, is the only system that will actually save us money?
Well, as best we can tell, I mean, the poor Congressional Budget Office was asked to look at lots and lots of legislation this past summer and struggled like crazy to come up with analyses of all these different permutations and variations on the Clinton plan. So I think it certainly has been a major challenge to the CBO, but the CBO has looked at single payer and Congressional Budget Office, and they've said, yeah, it's fully financed, and yes, we will save money doing it. As a matter of fact, some estimates are anywhere from $100 to $200 billion by the year 2004 would be saved by going to single payer by the control of excess costs that otherwise would be built into our heavily bureaucratic system.
And it's not just physicians for social responsibility who might be called liberal or some term that they're using to attack these days, but hasn't the College of Surgeons come out as well for
well, fundamentally, there's some real bad things that are happening to doctors, particularly specialists right now. Managed care is creating lots and lots of barriers for patients to get to specialist-type doctors. And because of that, what you've ended up with is a lot of doctors much more worried about losing their jobs. Let me give two examples. One of the big managed care companies in Massachusetts told their panel of psychiatrists that they weren't going to be participating anymore. You are fired, in other words. And they told all their psychiatric patients to call a 1-800 number and get a new psychiatrist. You say 1-800 if you're schizophrenic, right? You know, dial 1 if you're just anxious today. Anyway, there's that sort of thing going on. And in San Diego, one of the insurers there told about 300 different specialist physicians that they would no longer be part of their panel. And since this particular organization, it was a Blue Cross, I believe, had about half of the insurance business in the San Diego area, that was an instantaneous salary cut in half for those doctors. So some bad things are happening to specialists, and they're concerned. And the American College of Surgeons primarily said that single payer will provide open access to the doctors. If a patient wants to go and see a surgeon directly without having to go through a family doctor or a nurse practitioner or some other insurance bureaucrat, that they'll be able to go directly there. So I think they're enthusiastic about the freedom that single payer provides. I think they're a little worried about, you know, what, in quote, government control might mean to them, but they're enthusiastic about that element of clinical freedom. And no, it isn't just, you know, just liberal sort of characters that are enthusiastic about single payer. I mean, the fact is this is a very conservative spending program. We're in trouble with the amount of money that we're spending on health care.
So you're arguing this is the most fiscally responsible and conservative of the plans,
and at the same time the most liberal benefits. It's the best of both worlds. Liberal benefits, conservative spending. I mean, from my perspective, it should meet the best of both worlds for folks. I think that some businesses have recognized that this is a way to help control their health care costs and get the whole headache out of their hands. I think they worry a little bit about it because they're worried about having their dollars flow into, you know, something that they don't have control over anymore. And I think that there's that worry about loss of control. And there may be some fundamental philosophical differences here. I mean, there are folks out there who just believe that the government can't do anything right, in spite of the fact that they drive on roads, land in an airplane at airports that we've publicly built. They believe in our Army, which is publicly sponsored, but yet in the sewer system and water systems that are publicly sponsored, and in many parts of the country in public utilities, but yet they can't believe that we as a people can put together a reasonable set of controls that will allow for, you know, for a high-quality system in a public forum.
Now, the argument has always been that the United States is the only industrial democracy that doesn't have a healthcare system, and that it spends more money and covers the least amount of people. So if you looked at the stats on average, we have incredibly bad rates with infant mortality and other diseases. How come the public doesn't realize that? How come there isn't more support?
Well, I think that what's happened is that we hear the rhetoric over and over again. You know, we have the best healthcare system in the world. We have the best healthcare system in the world.
So we have the best healthcare on some that money can buy.
Yeah.
The problem is that it's becoming increasingly not
there's
affordable.
that. What I say is, well, we may have the best health care, we have the worst health care system. As a matter of fact, I usually joke, I say that we have a sickness care non-system, not really a health care system, because we focus
So
only
there's
on
really a
sick
problem with coverage and
Right.
delivery of the services?
Well, let me pose a tough business decision for you if you're the insurance industry. Do you want 20 to 30% of $1 trillion, or do you want 20 to 30% of $500 billion? Do you really want cost control if you're the insurance industry? The more money we spend, they get a percentage of the gross. They don't want the gross to get smaller.
So it's the old problem with the military. If you had a cost-plus contract, you, of course, always wanted the system to inflate.
Well, you want, no matter what business you're in, you want it to inflate. But there's some fundamental funny things about healthcare, which is that it's a cost. It's not, it doesn't improve our function as a nation to have healthcare, which is the maintenance function on our people, cost us more.
In fact, what people complain is they're paying more but getting
Yeah.
less health care.
Yes.
And now that the rules seem to be changing.
Yes.
I teach at a community college here, and the biggest complaint, I'm the faculty senate president there, is you start the year with a certain amount of physicians in a plan and a certain set of rules, and suddenly your physician's kicked out, and the medicine he's prescribed, they don't cover Celdane D, only Celdane, but Celdane D, you got to get it over the counter, and things are actually changing week to week, and it seems like they're spending thousands of dollars in booklets telling you who's been dropped from your system and what drugs you can use and can't use.
I don't disagree at all. That's absolutely true, and that's just part of the whole thing. Basically, what's going on is you've got managed care and business competing to control their costs, and the doctor and the patient are caught in the middle of it, right? We're going to ration care. They keep worrying, oh, we have a public system, we'll end up rationing care. Well, we are rationing care, one patient at a time, behind closed doors. I mean, that's what's going on. We're not getting the public debate about how we ought to be spending the healthcare dollar. They've got the dollars. They're going to tell us how they're going to spend the healthcare dollars on our behalf. We don't have control over the system anymore. And I think that's part of the problem is we need to put the user of the healthcare system, the people, back in charge of the healthcare system instead of having the doctors and the insurance industry in charge of the healthcare system.
How does the insurance company get away? In most cases, if I sign a contract and I provided services, how could it change so rapidly, almost overnight, with hospitals lost, doctors lost, clinic lost? How do they get away with that?
Well, I don't know if it's get away with it. I mean, basically what you're talking about is a set of complex contractual relationships that have to be there, and all those contracts come up for renewal, and people start debating and, going head to head, over whether they're going to get less or more money or how it's going to work or what the rules of that are, and sometimes people say, no, I don't want to do that anymore, and they're dropped. The other thing a lot of the insurance companies, of course, look at is what do things cost? Is this a high-cost facility? Can we save money by going to a different hospital? Play them off each other to save money, or play this doctor off that doctor to save money.
So is there calculation based on the best interest of the patient?
There's a tough question. What do you think? I mean, in all honesty, many of these insurance companies now are for-profit entities who have a fiduciary duty. The board of they have a fiduciary duty to their stockholders.
To maximize profit to the stockholders.
And if the stockholders don't do that, I mean, if the board of directors doesn't, do everything they can to maximize within the law the profitability of that corporation, the stockholders theoretically could sue them. So, I mean, you're in a situation where the rules are not directed at the goals that we want socially. This happens in my opinion, over and over in America. We pay people to do the wrong thing, and then when they do it, we moan about it. And this is the same thing with the insurance industry. These are not evil people. They're not bad people. They're just trying to work within the rules, and they're looking at what those rules tell them to do. And the rules tell them if you want to maximize your profitability, you avoid sick people. You try to
pre-existing conditions.
Right, all the things that have, scandalizes. If you have a doctor who has a lot of sick patients, there's a good way to get those people to change insurance. Kick their doctor out of the plan. They'll probably follow their doctor. All those sick people go with them. I mean, there's just a lot of things about the way the system is set up that's going to create some very perverse incentives on the part of the insurance industry. And again, it's not that they're bad people. It's just that there you are. This is what you're supposed to do. Maximize the bottom line. These are the tools that are available, and they result in socially unconscionable behavior. So I think that we have to look at what we're about. I think fundamentally, I don't understand how we as a nation can have such a bloated healthcare system and see that as something that we want to continue to have as a source of profitability for the people who are involved. Unless you're going to pay people to do what I mentioned, which is actually to keep people healthier and reduce the size of the system. Let me give an example. Say I want my house painted. Can I set up a little company outside my own home with one customer, me, that I own to paint my own house to make a profit off of it. I mean, that makes no sense at all. I mean, what I'm thinking is that the healthcare industry in this country really provides maintenance on the people that produce all the other goods and services that we need. The more money we spend on trying to keep the public healthy, the less money we have for other things. You can't set up an organization to do the maintenance on your own people and have it be based on a for-profit system.
What are the administrative costs? You keep hearing that the Canadian system's costs are much lower than ours.
Yeah, I think it's pretty easy to understand, actually, why we have higher administrative costs. A single payer is always going to have lower costs, even if it's less efficient than private industry. And this is why. Number one, you don't have to do marketing. In my HMO, we spend 3 to 4%, and that's not a lot compared to some of these HMOs in terms of the amount of money that's spent on marketing. I don't have to do eligibility to figure out whether someone's, on
Everyone's universally eligible.
Everybody's on, that's right. So we have in our 25,000 member HMO, we have a full-time person who does nothing all day long but try to figure out whether it's our bill to pay. I mean, that's her job. I mean, you've got that overhead. You've got to do the billing. You've got to do the paper processing. And you have in every one of those 1,600 different insurance companies a chief executive officer, chief financial officer, and I have to have an information system and all the other things that go with it. So you've got all those things reduplicated in a way over and over again throughout the industry. When you have a single payer, you don't have to do any of those things. The collection mechanism is very simple. It's taxes. And it's very fair, because you can make it graded. So, for example, if you do a payroll tax, those that earn less money will end up spending less money for their health insurance than those that earn more. So it's a very, what we call a progressive tax rather than a regressive tax. Right now, the chairman of General Motors pays $4,000, $4,500 for his family's health insurance. His $25,000 secretary pays $4,500 for her family's health insurance under the company program. How regressive can you get as a comparison in terms of percentage of income?
Speaking of the chairman of General Motors, there was a quote from him somewhere that he thought the single-payer system may be the best option for big business in the United States.
I think it is. Most of the programs that have proposed single-payer from the perspective of big business have come up with a number of around 9% of payroll as the percentage that we would need to end up having about the same amount of money out of business that they're currently putting into the system. Well, for many of these corporations, they're spending 13%, 14%. That's a huge savings. So what we're doing is we're saying we're going to give you guys, you businessmen, some of that money back that we're going to save by eliminating this excess bureaucracy. We're going to put it back into your businesses so that you can hire people for real jobs instead of having a jobs program for paper pushers, which is what the insurance industry used to be.
A few years ago, the estimate by the auto workers, Chrysler put out saying essentially the Japanese had the advantage because of their healthcare system of a V6 engine.
You got
for every car.
They get a free V6 engine versus us because it's so much more efficient. And that's true. The Japanese spend about half on a per capita basis what we do on their healthcare system. Now, I'm not saying we should spend half of what we're spending now, in all honesty. I'm just saying let's spend what we're spending now, and if we did that, we could have literally the most comprehensive high-benefit system in the world. Go ahead.
What I was going to try to say when I hear about this is that single payer has been being used as a scare tactic. Hillary Clinton recently made a speech warning the insurance industry that
I hope she's right.
if the Clinton plan failed, that single payer would sweep the nation.
Yeah, I hope she's right. I think there's some truth in it because, in all honesty, what could happen is with the current system that we're on is we're going to see more and more people uninsured. We're going to see more and more unscrupulous insurance practices because of the severity of competition. And what's going to happen is we'll have more and more dissatisfied people when they turn and look around and say, what do we do now? We're still going to be there. Most of us that are talking about single payer are in it for a lifetime. I was talking to the guy who I worked with in the Sandusky area, who, when he worked on the Roosevelt campaign as a young man, was told that they were going to get a national health program out of Franklin D. Roosevelt.
And then Truman
and he's still working on it. Yes.
And Truman had the big fight in the late 40s.
And Nixon, Kennedy debated it, right? Because Kennedy wanted a national health program. So every decade or two, we seem to get around to this again. So I suspect, when I'm an old guy, I'll still be working on it. I mean, we'll see. I think there's a tremendous opportunity in California. So
as we speak, on the ballot right now in California is a single-payer initiative.
Yeah, it's a fun story. So maybe I'll talk about it a little bit. Probably the beginning of this year, there was a group of activists in California, mainly Neighbor to Neighbor, and some physicians and Physicians for a National Health Program, Gray Panthers, and people from AARP, who were kind of interested in thinking about an initiative in California, a ballot initiative. California has a very good ballot initiative program. If the people put a ballot initiative on and they vote for it, the legislature can't change it. The only way you can remove the law from the books is to have the people vote on it again. So it's a very powerful initiative, and you only need to get one group of people to sign up to put it on the ballot. You don't have to go through a whole lot of hoops like we do here in the state of Ohio. We have a much more complicated initiative process, and some states have none. So this is an opportunity for the people to say, this is what we want. Well, they were surprised when they kind of put feelers out. Well, will you give us a little money to try this? They were able, in a very short period of time, to collect $250,000 from people that were interested in seeing people try an initiative in California, and that encouraged them. And then a number of other sponsors, including some union folks and what have you, came on board very rapidly. And over a period of 10 weeks, they collected more than 1 million signatures in California to put that ballot initiative onto the ballot. It's never been done that quickly before. By the end of the campaign, they had 10,000 volunteers working on it. They were collecting nearly 100,000 signatures a day the last couple of days on the campaign. They had that many people working on it. So it literally caught fire out there. The other thing that is amazing about all this is that they've been able to put together a coalition that is relatively strong. They've got almost 5 million membership. The membership of the people that are sponsoring single payer in California, the California membership alone are about 5 million people. If all 5 million of those people voted for single payer, they would pass the bill in the state of California. So they've got a broad-based coalition of people that are interested in single payer there, and they have a good shot at passing it. And then the last little miracle in this whole thing is that there are very hotly contested senatorial and governor's races, and the whole House is up for election, as you know. And what's going to happen is the advertising campaign that the insurance companies would otherwise use to put lies till till the end of time on television, to suck up all the advertising time. They can't do that because the congressional campaigns and the governor's campaign and the Senate campaigns have bought up a lot of the advertising time, and we'll probably be able to match them truth for a lie out in California with a little bit of support.
So they can't buy the election?
They can't buy it. No, we're going to be able to go head-to-head. Now, if they had open advertising space, they'd be able to outspend us, 10, 20 to 1 on this. But they're probably not going to be able to do that because of the limited amount of ad time. So that's a mini miracle that we aren't going to be able to, that we will be able to meet them on an even plane in the advertising area.
So there's exciting things happening out in California.
It could really happen. We might really get a single payer. And the interesting thing is California, if it was a country, would be the 8th largest country in the world. So it's a huge state. It's among our biggest
much more. Twice the size or so of Canada, much larger system.
It's about the size of Canada, actually. So what
in terms of total population.
So we're talking about a situation where, with a little bit of luck, we can really have a genuine opportunity to look at whether single payer can genuinely work in the United States of America, put together by a group of dedicated people and tried to put together to be run for the benefit of the people rather than for the benefit of the insurance industry.
Okay, what about back here in Ohio? Exciting things happening here?
Well, not as exciting here. I mean, as you know, we were the first state in the country to put forward a single-payer bill. Bob Hagan out of Youngstown had one in the hopper in 1988 and 1990, and we couldn't even get it out of committee, primarily, I think, because of Mr. Reif, who really didn't want to bring it out of committee. And poor
man traditionally associated with insurance money.
Yeah, so
there's a real line. Well, we've said it on many of my shows before, is that there's a clear difference in Ohio between Vern Reif and Democrats and the Republicans. The Republicans get their money from the banks and manufacturing, and Vern gets his from the insurance industry.
Well, anyway, the fact is that they couldn't get it out of committee, and Vern wouldn't let it out of committee. And I think that frustrated Bob Hagan quite a bit. Now Vern is going to be gone now, and Bob is...
One of his last acts was to try to take Representative Hagan out in the primary, which failed.
Yeah, so I think we'll see what happens here. I mean, it's possible that Representative Hagan will come back and reintroduce that bill. We're certainly trying to encourage him to do that. I think the other thing that's interesting is that we're moving ahead with what I think is a very shoddy approach to trying to patch up our already badly damaged healthcare system here in the state of Ohio through this bill called Ohio Care. And
Well,
I'm
the
very
governor
concerned about
is
that.
touting that as one of the great innovations of modern policymaking.
Yeah, well,
You tend to disagree?
I would tend to disagree heartily with him. I mean, remember, I'm a guy who has been deeply involved in running a Medicaid HMO, and what I can tell you is that even with people who voluntarily want to put themselves into a Medicaid HMO, it's hard to make it work for them, very hard to make it work for them. You've got to have telephone communication with physicians, you've got to have transportation to get to doctors' offices to avoid running into the emergency room. You've got to have enough primary care doctors, and there aren't enough for all of us to do this. I mean, these same HMOs want to put middle-class people into HMOs and have us do the gatekeeping for them, for the middle-class folks. At the same time, they want us to do it for Medicaid. They're not going to
So
do
this
primary
would
care
be,
doctors to do it.
Ohio Care would be a poorer person's HMO?
Oh, they're going to put all of the Medicaid individuals into HMOs, and then they say they're going to save enough money after they put all of Medicaid into HMOs that they'll be able to expand it to the rest of the working poor, you know, up to 100% of poverty. And I just don't believe it can be done. Not only that, I think that you're going to not have enough primary care physicians to really make the thing work. And you're also, most unfortunately, at risk for damaging what is a very fragile but very important piece of trying to get health care to the inner city poor and to some extent even to the rural poor. And that is a number of the community health centers that are sponsored by the federal government to provide care in these poor neighborhoods.
By getting they're asking for a waiver, right?
Right.
From the federal government.
Right.
Are you saying that a response to that may be to shut down the federally funded clinics that service some of the poor population?
What I'm fearful is that they'll starve out. What could happen, you see, the federally funded clinics currently can bill state Medicaid for services that they provide. If the Medicaid HMOs get all the money, that there will be no state Medicaid to bill. And if these organizations are not part of one of these HMOs or a contracted provider in one of these HMOs, then they aren't going to be able to see their patients. And if they do provide care to someone who's not part of the groups that they contract with, they won't get paid for that. So I'm afraid that they're already right here with their financing. They'll be up to here in the water if they're not able to collect. The public health department, similarly, they do HIV follow-up, they do tuberculosis follow-up, they do gonorrhea, syphilis follow-up, sexual transmitted diseases follow-up. Those people are also at the current time able to bill for that and immunizations. They do a lot of immunizations. They're able to bill for immunizations back to Medicaid for poor populations. And if the HMOs have that money, they won't be able to bill the HMOs, and yet people will probably still come to them expecting immunizations, expecting that sort of public health infrastructure to continue to work. And I'm afraid that this particular bill hasn't taken that into account adequately.
If the federally funded clinics collapsed in those primarily poor areas, is there anything in the bill that would require that the state move into those areas and provide services?
I don't know what they would do. They're controlling the money. They might put pressure on the HMOs to try and pick up the pieces in those areas. I'm sure the HMOs will protest that, oh yes, we'll do that. We need them. We're going to want their doctors. But I'll wait and see just what happens. You know, I'm very fearful for that. I think that these are essential community providers of care in some of these fragile urban and fragile rural areas. And I'm just fearful of what it will mean. And I don't really think that when you push all of Medicaid into health maintenance organizations, that it's going to be all hearts and flowers and roses for the doctors or for the hospitals or for the insurance companies in terms of trying to manage a group of people who really maybe don't have the resources to really fend their way through the complexities of managed care. It takes a lot of effort to know, which hospitals you're supposed to go to, how you're supposed to contact a doctor, to have the phone and have the phone bill paid so the phone's working when you're supposed to contact a doctor. All these rules and regulations are going to really be a struggle for a lot of folks that are on Medicaid. I can just see a Medicaid mom with no phone with a sick baby in the middle of the night. She's going to take her kid to the emergency room. The emergency room isn't going to get paid. The emergency rooms are going to be screaming. The HMOs are going to say it wasn't pre-authorized by the primary care doctors, so we're not paying it. It's going to be a mess. It's going to be a mess.
Okay, and one of the things that would help solve this mess, in your mind, is
one
single payer.
One system for everyone.
For all Americans.
No questions of eligibility, that people can use health care when they need it. We're still going to have people who maybe are using the system inappropriately, and we're going to have to look into that. But we'll have the data to look at who they are. We can target, if we want to encourage primary care physicians to work in inner city areas. Hey, with a single payer, you can say we're going to pay you more if you work in that area.
Because that's been a critique of all the plans is single payer may cover everybody, but you've still got the question of access.
Right.
If I'm covered and there's no primary physician around, what am I
So-
gonna do?
But you can target, you can provide rewards for people to move into those areas, you can pay somebody more. You can say, okay, we're gonna pay $35 a visit in Worthington, but downtown here in the middle of Columbus, we're gonna pay $45 a visit if you're willing to come
Or
down
if you're
here.
willing to go to the Pine Ridge Reservation where...
Or whatever, yeah. So you can put the money where your need is. Right now, what we have instead is a system where people will chase the money, but where's the money? It's in the suburbs, it's not in the inner city. So we get excess services to the worried well and inadequate services to the urban poor who are ill. And I think, and to the rural poor who are ill. So I think it's a major challenge to try and readjust that money, but with a single payer, you would be much more quickly able to target the rewards for physicians and the rewards for other institutional providers to get them encouraged to go where the need is.
Okay, well, thanks a lot, Dr. Jonathan Ross.
Thank
We're
you,
going to
Bud.
look at a clip from the forum that you did here in town.
Okay, great.
As well as we're going to talk to a local activist who's working on behalf of single payer.
Thanks.
Congratulations, and keep up the good fight.
Great. Activist program, we all know that. I mean, you have to think about how can I help in any way that I can or to make this thing go forward in some way wherever I can. And that's why I would encourage all of you, again, call your relatives and friends in California and tell them about what they can do for you out here. It might take a decade to get here, like in Canada. It took 10 years to go from Saskatchewan to Quebec. But it got there, okay? It went one province at a time. They had an insurance system just like ours, a private health insurance system, before they chose to go with single payer. So it can do that. It can move that way. So we need to be supportive of what's going on in California right now, because that's where it's at. And to some extent, we had a lot of people doing a lot of lobbying and working with the Congress people, trying to move them a little forward or open up their minds on this, because we were doing something nationally when the activity was there. When we had a single-payer bill in front of the state legislature, we were trying to support Bob Haley. So you support it globally wherever you can. In terms of action, what you need to do is you need to be talking to friends and neighbors. If you've got other groups, one of the things I should mention, and again, I've done most of the speaking for our group, but there's a couple other people who do some speaking too. Is you need a couple of people who are willing to go speak, who will stand up and speak on this issue, and they don't have to be experts. It helps me because I've got credentials. I mean, it's good. I'm a doctor, you know, and that just automatically gives me some standing. But I really don't know a whole lot more, in all honesty, than a lot of other people in this room right now about this. I mean, there are lots of people who understand this, and maybe understand it from a more personal perspective than even I do, having lived with problems with the healthcare system or being inside of it. You need somebody who can act as a speaker. Each of your different groups, I mean, how many groups do I belong to? I mean, I belong to a whole bunch of different groups, and what I've done is I've asked, will you let me speak? You know, will you let me talk to the group? You know, and they're not groups that are interested in healthcare per se, but, you know, they get together for other purposes. And a lot of them have allowed me to do it. And the same thing with a couple of our other speakers who belong to a lot of different groups, and they've been invited to speak with those people. So I think that this is something that we also need to put together as a core group of people that aren't afraid to get up and to speak. And you've got several ministers here who are very eloquent, and, you know, push them a little bit, you know, pull them into your group. If you've got another connection, you can get 20, 30 people together. You know, it's worth it. He's talking about passing out some literature, letting people answer some questions, especially those myths. You know, the government can't do anything right myth, this is socialized medicine myth, they'll be rationing myth. I mean, all these things are myths that have not come to pass in most other single-payer systems. Most people are quite ignorant. They've had tremendous disinformation put out there about Canada. It's an opportunity to
a number of us want to know about
yeah, it's an opportunity to kind of demythologize this.
Honey, who's our congressman?
Oh, you know, we voted for him for years.
Well, we got to get him to support single-payer national health care. It's the best system, the only one that works.
But he gets a lot of pressure from the insurance companies.
And votes from us.
What are you doing?
I'm getting his number. I'm telling him to support Wellstone McDermott Conyers single-payer bill.
That's a lot of words.
Well, then it's something he'll understand.
Here with local healthcare activist Steve Canner, and Steve's gonna let you know how you can get involved in fighting for single payer. Now that you're inspired after hearing Dr. Jonathan Ross. So what are you doing locally, Steve?
first I want to second that. It is inspiring to hear Jonathan speak, and it moves me to keep working on this issue. There's a group here in Columbus called UCANCO, Universal Healthcare Action Network of Central Ohio, and we've been working on single payer as an organization for the last year. Although a lot of us have been working for a number of years here in Columbus working on this issue. And we hope, though, to keep growing with this group. And we're working on a number of different things. One, we're working on the issue of Ohio Care. We want to explore it more, learn more about it, and learn how we can see if we could derail some of the most negative aspects of it. So that's one thing. We're planning on November 12th to have an information hearing. And I'll give out a number later from our group that people can get in touch to get more information about that. We're also starting to talk to some of the people in Columbus City Council and perhaps some of the other city councils around the metropolitan area. We had a meeting, a few of us, with Les Wright, and brought up the idea of a resolution supporting the national single-payer health care plan, which is known as the Wellstone-McDermott bill in Congress. It didn't get much attention. The newspapers are ignoring it, and obviously there's a lot of money floating around this issue, and the insurance companies have a lot of stakes, so they're going to try their hardest to put the squash on it. But in any case, we're trying to build a grassroots campaign and talk to people like Les Wright as a city council person and tell her that it's in the best interest of the city of Columbus to support a national single-payer.
Okay, this is Columbus,
campaign.
Ohio, the headquarters of Nationwide Insurance. And is that going to be a tough sell there, Steve?
Well, as you and your audience well know, there are certain powers that be that control this city, and certainly the Nationwide execs are part of it. And it's a tough sell, and we have to, I guess, be more assertive and just be more staunch in our support of what we feel is a just cause. I think we can make a sell of it.
Okay, so other things coming up, you got a forum, any more events like what you're doing here with Dr. Ross?
We just turned in some petitions for to our U.S. congressional representatives for support of single payer that we got close to 1,500 people to sign. And right now we're reevaluating where we're at. People are certainly welcome to come to our next two meetings we're having.
These are regular ongoing meetings?
Ongoing meetings, and to talk about what's the next step we take. We want to talk about an organization. I know that's kind of boring, and but if you're into that and want to meet some other people, you're certainly welcome.
When do these meet again?
This one's going to be Monday, October 10th, and that's at the Summit United Methodist Church at 82 East 16th, which is across from Ohio State. So we welcome your input. And you can call us at 424-6203. And if no one answers, leave a message that you're interested.
424-6203. That will be up on the screen.
Those magical numbers. And we're also then we're going to start investigating the possibility of single payer coming back as a state bill. And there's been talk throughout the state, and we're all real excited about that. And that's something to rally around like we did before. And we're going to talk to maybe some of Representative Bobby Hagan's folks here in Columbus, see what they have to say. And if it is a positive, we're going to start going forward and organize here in Columbus, and we're also going to try to make some strong coalitions with people throughout the state.
Are you urging your people to send any resources to California? Do you see that as an important event?
Well, it's real important. Our resources are kind of limited, I think, as in most groups. And
you haven't got that grant from Nationwide yet, or?
I think it's in the mail, is what they said. It's coming any moment, and so is the Messiah, but we don't know when. Certainly, we would urge people to, at the least level, to write relatives. In fact, I've got some cousins that I haven't written for quite a while, and it's time to write them and tell them to support this bill. So I'll be writing my cousins Lori and Tom.
Could you envision if things pass in California and the system catches on, maybe there'll be a day when we have such an initiative in Ohio?
Well, look, we're going to have a new speaker soon, so anything is possible in Ohio. We're done with King Byrne, and hopefully we'll get someone who's a little more progressive and a little more open to ideas that will help all of the citizens of Ohio. So I am optimistic. If this thing can pass in California, even if it doesn't pass, I think it's going to send shockwaves that we're going to feel here also.
Okay, well, thanks a lot, Steve. Again, remember to call 424-6203 if you want to get involved in the battle to bring single payer to Ohio and to the United States. Thanks a lot.
You're welcome. You.
These are scenes from the hit show MASH, where doctors and nurses operated a compassionate yet comical Army medical unit. In almost every episode, the cast of characters talked about going home, about returning to private practice, to the routine delivery of health care, far away from the battlefields.
I can't wait to get back to the States and work in a real hospital with sanitary conditions and regular shifts and plain old ordinary diseases.
I doubt that the characters on MASH would ever have imagined our country as a place where getting routine medical care isn't always routine. They couldn't have known that for many people back home, the fight to get health care would become a real battle. After all, that was a TV show. And this is the real world. That's why we'd like to introduce you to someone who can talk about the real world of health care and the debate over the kind of health care system our country needs.
Hi, I'm Greg Asher. You and I need to become involved in the healthcare debate. You and I need to become more informed about the various healthcare proposals being offered. We need to communicate our views and opinions to the elected officials. Why am I making this pitch? Because people with disabilities have something special to offer the healthcare debate. We know that any system that serves the needs of people with disabilities or people with chronic illness will serve the needs of all people. You may think that I'm just worried about myself, but I'm not. I'm concerned about a good healthcare system for my family, my friends, and my neighbors.
Greg's neighbor, Narciso, is worried about health coverage for his daughter, Lupe. When she finishes college, his insurance plan won't cover her. He's concerned about whether or not she'll find a job that provides health care benefits.
Hi, Mary. Where's Bob at?
Hi, Greg. He's off at work today.
Bob and Mary both work hard. Like other families, one of them has to work just to provide the family with health insurance.
Can you turn me into a beautiful mommy?
After all, no parent knows what the future holds.
Hi. Hello.
Single moms like Victoria and Pam may have basic coverage for their children, but they may not get any regular health care for themselves. You've got to wonder, what happens to their children if something happens to them?
Greg sees Bob and Kayla dropping by when they can.
Beautiful day.
Hi.
They have invested everything in their own printing business, and they really feel the pressure. They have their own family to take care of, they look after their parents, and they have their business worries.
They try to provide their employees with decent insurance coverage despite the cost.
Hi, Greg.
Small business people aren't alone. Big businesses can't keep up with the costs either, and they just keep getting passed along to the consumer anyway. No matter how you figure it, we all pay for it.
Every parent on the block worries about the unexpected. We all know that children can seem like accidents just waiting to happen. Sometimes our children will grow up to face more than scrapes and bruises.
We all know someone with diabetes, someone with arthritis or asthma. We may know someone with a birth defect or someone who is developmentally or physically challenged. For them, the big healthcare obstacle is accessibility.
We often have trouble getting insurance because of what insurance companies call pre-existing conditions. If our condition signals a health care cost, we are not insurable. Oddly enough, it's against the law to drive a car without insurance, but not against the law to live without it. That doesn't seem fair, does it? What we need is a system that is fair to everyone, that puts people first.
We want a system that does not discriminate against people because of health-related problems.
We need preventive care and services that promote our ability to function at the highest level possible. We want a system that is less complicated, that makes life easier, not harder.
We need a system that serves people who live on farms, in small towns, and in big cities.
We want a system that's responsive to individual needs. We need a healthcare system that lets us choose the doctors and providers we want.
We need a system that is financed fairly.
Considering what we spend on illnesses which could have been prevented, on uncontrolled costs and paperwork, we ought to be able to spend more money to provide basic health care for everybody.
If you believe in putting people first in the debate on health care, then pick up the phone and call the Universal Healthcare Action Network at 1-800-634-4442.
The responsibility is yours. You take action.
We all need to get the facts and then educate our representatives in Washington and at home. The message is simple. Let's put people first in one system for everyone.
The care is all broken up, it's fragmented, the doctors don't communicate well with one another. It's mainly specialists and surgery-oriented, you know, the surgeons get more money than the thinkers in this business. You know, they cut or do a procedure, you know, their guys, for example, spend 15 minutes looking down on somebody's stomach, and they'll make as much doing that as if I spent with two different patients that were very sick, an hour and a half on each of them. You know, they'll get the same amount of money for 15 minutes looking down on somebody's stomach. I think that this is very specialist-oriented. So therefore, what we end up with is a system that's dominated by specialists. They've got money and therefore power. In addition to that, the specialists are what you want to be when you're in medical school because they'll get money and get power when you're a medical student later on in your life. So what we end up with is 70% of our doctors are now specialists and only 30% of them are primary care doctors. So when you really need a doctor who's got a general view of you, who knows you as a person rather than as the gallbladder, we joke about the gallbladder in bed 32 or the heart attack in bed 144 or whatever. You know, instead of being focused on it as something that's special oriented, you're focused on it as a person. We've got catastrophic healthcare costs. We've gotten very good with our technology. That technology is very expensive. If you have a premature baby, it may run $100,000. To do a bone marrow transplant on somebody with leukemia or with advanced breast cancer to save their life may run $100,000 plus. So we've got these sort of things that we're doing now that are huge ticket, and catastrophic healthcare costs have become the #1 cause of personal bankruptcy in the United States of America today. And I think that says something awful about us as a country, that we're willing to let our citizens end up bankrupt. In addition to this, because for the insurance industry, a sick person is just like if you want to sell home insurance, and somebody says, yeah, come on out, I want to buy a policy. And as the insurance agent walks up the sidewalk and notices that the house is on fire, and you say, quick, let me sign that policy. He's not going to take, forget it, I'm not selling you home insurance, your house is on fire. Well, a sick person is a house on fire for health insurance bill. And they don't want to sell insurance to people who are ill. And yet we've got to take care of people who are ill. And I don't think this nation, I just don't see it in our national spirit to let people die on the street without help. I mean, I just don't think we're up to that. You know, I think we believe that we should be taking care of each other. I think most Americans fundamentally believe that health care is something that everyone ought to have. If you don't want to call it a right, you still say we're all better off than the other guy has it. I mean, if we're not, think about contagious diseases. Certainly it's much better off if people with tuberculosis get their tuberculosis treated so they don't cough the germs on the rest of us. I mean, some of these things we can actually catch, can actually be harmful if they're not treated. So, to some extent, I think healthcare is what's called a public good. It's something where I'm better off when you have it. Because ultimately, if you're ill, you're going to be disabled, you won't be working, you won't be paying taxes, you'll be in a hospital bed, and my products that pay for the products that I buy that you manufacture as a worker for a company, they have to build the cost of that health care into the system. So when people are sick, it costs us all more, one way or the other. It's kind of hidden. We don't get to see it in our current crazy quote system. But ultimately, the cost of sick people come down. You know, no matter how much money it makes for the insurance industry, all the rest of us are the ones that are feeding their money into their pockets. We need to understand that. That's what's going on. The system is multi-tiered. We talked about the cost shift. When people don't have insurance and they end up sick in the hospital has to charge everybody else more to make up the bad debt. Well, the system is multi-tiered, and that's one of the reasons there isn't just cost shifting for those that don't have insurance. There's cost shifting between Medicaid and general relief, which pay very little money, and the other systems as well, or from Medicare, which just barely pays enough money to some extent. For some diagnoses, it pays enough. For other diagnoses, it does not pay enough to the hospital. So we end up with this army of accountants who keep trying to figure out what are the better things to put in the hospital, what services should we brag about so that we can get people in here because Medicare pays better for them than others. And you get this whole army of people who are involved in this cost shift because the system is multi-tiered. And because the system is multi-tiered, there are winners and losers. And doctors end up, instead of doctors focusing on someone sick, they have need for health care, they end up focusing on a lifestyle. You know, they want to know if you have insurance, is there money in your pocket before they want to do something to you. So care gets focused on money rather than focused based on need. And again, having multiple systems is what creates this. Lastly, we've got the whole issue of the bureaucracy that's necessary to run healthcare. You've got, as I mentioned, 1,600 insurance companies across the country, 300 plus in the state of Ohio. Every single one of those has a chief executive officer, chief financial officer, chief operating officer, an army of clerks, and every one of them has an army of lawyers that are setting up contracts between the doctors and the hospitals. And then on the doctor's side, I have to keep track of all that. I have to have an accountant to figure out all the bad debt and the complexities of that, and the hospital has to do the same thing. If you want to know why an aspirin in the hospital costs $7, it's because it's $6.90 worth of accounting costs and to pay the bean counter and 10 cents for the aspirin. I mean, that's what's going on in that circumstance. I believe that's true. That's absolutely true. Malpractice costs, about 30 to 40% of malpractice premiums in that range are related to the fact that if I hurt somebody in practice of medicine, that I have to guarantee their ongoing medical costs. So, for example, if I get and they, it's the wrong pill, and they collapse, and they have a stroke, and now they're crippled, and they're going to need ongoing medical care for their stroke, not a bad judgment. That person, if they go into court, I will have to pay, as part of my malpractice judgment, for the ongoing care for that injury. Even if they have insurance that covers it. Even if there will be no out-of-pocket costs to that person because their insurance will continue to be enforced because they've got it through their employment. And the reason we have to do that is because we don't guarantee that in this country. And for the very same reason, in addition to malpractice costs, we've got medical piece to your automobile. There's a medical piece to slip and fall. There's a medical piece, for your liability to slip and fall in your home. There's a medical piece to the liability for product liability. There's a medical piece of workman's compensation. Okay, so we've got all these pieces, once again, which require bureaucracies to maintain them, all of which benefit the insurance industry, which have additional costs that are involved in it. Just like malpractice or duplicative, if we have a system that covers everybody comprehensively with no question of eligibility, or if you're a citizen, you're eligible, then none of those costs would be necessary for those other insurances, and we would be able to save that money, put it in our pockets, or be applicable to a healthcare system to pay for the things we really need in the healthcare system. There's a whole issue of unnecessary care. They're going to have significant catheterization done by doctors are unnecessary. A significant number of cesarean infections are probably unnecessary. A significant number of heart bypass surgeries have been estimated to be unnecessary. All those things are questionable care that may be being done because there's money in it or because we don't get the information to tell us what really works. And until we focus on looking at the quality of the system and get some data about, given individual physicians or given hospitals, we're not going to be able to sort out who the troublemakers are and see if they're troublemakers because they're juicing the system or are they troublemakers because they just don't know any better and they don't know they can do a much more efficient job and can be taught something and change their behavior.
How can we solve the healthcare crisis?
Both Ralph Nader and the president of General Motors say that single payer is the answer.
And when those guys agree on anything, we should shout it from the rooftops.
Send up a flare.
How about a Roman candle?
Single payer.
The only plan that works.
They come around my head. Oh, the pressure.
I'm getting these terrible mood swings.
Oh, I get this terrible heartburn.
You are watching ACTV 21, the community channel.